Good afternoon to you all from London. It is nice and sunny today. Yesterday was gloomy, so the weather is good at the moment. It's holding itself. It's late November. It's a very pleasant times. So thank you all for coming over. On behalf of Sadiq International Virtual University, welcome you all to this, what I hope will be a phenomenal session, a webinar on a very, very tricky subject of deafness and hearing impairment, which I call a malady which can be treated. I borrowed this word from the famous book written by what was his name, the Emperor of All Melodies, by I think somebody who works at Columbia with Azra. So that was about cancer. But I think deafness and hearing impairment is a remediable malady. We can prevent it. We can also control it. We can also treat it. And if you cannot, at least we can rehabilitate. So that's the whole thing. So what I'll do is I'll straight away go on to, and of course, introduce all of you when you come over. That is my task. So we'll see. The background is that Sadiq International Virtual University came into existence, formation in 2020, March or April, when the COVID was hitting us and we were all scared. We didn't know what to do. So I thought we'd start an online education program. So Medics International is a global NGO based in New Jersey, Princeton in New Jersey. And it's an accredited NGO with United Nations, works on different things, including disabilities and handicaps, apart from other things like natural disasters. So when I was the global president of Medics International, it was my desire that we should start an online university program with a view to establish a university in Karachi or Lahore in Pakistan. So we started with this, and there were only 5 or 6 of us in May of 2020. Shahid was one of them. Sholeh Bijgali from Tehran was there, and there were a few others. It started very, very primitively, but now it's taken off pretty seriously. And we have something like 4,000 unique email addresses with us. And they're all senior teachers. They're not medical students. They're very seasoned professors, teachers, academicians, deans, vice chancellors, even policymakers. Like we have people like Professor Shahid Mahmood Beg, who's the president of the Pakistan Science Foundation, and so many others. And we are reaching out to something like 53 countries. So what we do is we do webinars almost every 2 weeks on different aspects. Medical education is one field, but today is deafness and hearing impairment, which is close to my heart. But we also do workshops, and we are now also going towards running courses. So we are running a course in certification in medical education, also a diploma course, and soon we'll be starting a master's program. We're also looking to disseminate practical skills through demonstration of surgical things, and that is where Harun and Naveed will help us when we come towards the end. So let me just talk briefly about deafness. And this is borrowed material. This is not my material. I borrowed from WHO's website that all of us are familiar. It's nothing unusual. Because this is being recorded and because this will go onto LMS, our learning management system, so it can be used asynchronously for anybody else. So a lot of this material for you experts is old. It's nothing new in it. But because a lot of other people also, general practitioners, medical students, doctors, we have something like 3,000 people who join our webinars and read later on through our very advanced LMS, which is run by Mubashir Iftikhar in Malaysia, and it's AI-based. He's using artificial intelligence development again. So that's the reason I'm just going through these few slides, and then I'll hand over the talk to Patricia first, and then of course Shahid and that all. Everybody knows, but I'm just defining this, what the WHO says about hearing loss. I will not read it. It's already there. It'll be recorded. All of you are familiar with it. But the important thing for people who are not related to ENT is that deafness and hearing impairment are 2 different things. Hearing loss is a better word they're using these days. And just like visual handicap and total blindness. So there are different definitions. This is what WHO says, that it could be mild, moderate, or severe, or profound. Everybody knows in our field, but for people outside of ENT, it might interest. Disabling hearing loss refers to hearing loss greater than 35 decibels in the better hearing aid. I'm sure people will tell us more about it. Whether it's 35 decibel, I'll just switch off the phone. I forgot to do that. I'm sorry, seriously. Do apologize.
Dr. Mubashir, go on slide mode.
Just trying to stop this phone. Okay. So, Mubashir, if you can kindly do that. But anyway, we'll just carry on like this. Now, nearly 50, forgive my spelling, so nearly 80% of people have disability, etc. You can read it. I'll just go through 5 slides and then hand over to you because really interesting people sitting out there. This is what it's called the global burden of disease. That 3 or 4 terminologies which are commonly used by WHO. Global burden of disease, one, then there's QALYs and DALYs. I'll tell you in a moment. Over 1 billion young adults at risk of permanent avoidable hearing loss due to unsafe listening practices. This is something that's come up in the recent past because of all these. Everybody, you go on the tube or a train or a bus or wherever, you find that somebody has things in the ear, and some of them could be quite deafening. So that's a problem that's new one. In the olden days, that was not such issue. And of course, we all know that's highly significant in less developed countries or developing countries like in Asia and Africa, Latin America, South America, etc. And we have Professor Patricia, who will tell us about South America, Guatemala, and Argentina, and these places. Over 5% of the global population requires rehabilitation. I think I'm one of them, and probably I'll come to one of you in due course of time for a hearing aid. Aging is an important factor. Now, what has happened in 60 years is really, it sounds too early for me because people are living 90 at the moment. This is an old document, but this is worth remembering that aging is an important factor, and that's where we can help. And technology can help. Of course, this is familiar to you, prenatal, intrauterine, etc. Now, what is missing in this conversation, in this these slides from WHO? You see genetic factors, hereditary, non-hereditary, etc. But I'll tell you in a minute what's missing. Perinatal birth, asphyxia, etc., low birth weight, we know about these things. What is missing on these slides is consanguinity. Now, when I was working for WHO and we did a lot of collection of data from different countries in the Emerald region, Shakil, who was my student, a dear friend, he could not attend today, he did his master's, his PhD in Manchester, and I was supervising it. And consanguinity turned out to be a very important factor in the Asian population, in Pakistani population. We also got the data from Egypt and other places. Now, this is not mentioned in the list of causes in WHO's website, and this is what we would like to discuss. Now, the question is consanguinity an important cause or not? Experts will tell us. Then, of course, we know that chronic ear infection, middle ear, meningitis, etc. These are common causes, which I've seen in Iraq also, where I go quite regularly. Habib Shoaib is there from Kufa University, he'll tell you. But the prevalence and the incidence and the complications that we saw in Pakistan, you don't see them in these countries like UK or USA or Europe. Meningitis was a common thing that we saw regularly there. Now, the other common factors like impacted wax, which is, of course, known to us. Of course, noise-induced hearing loss is an important factor. That was a specialty that we did. And this is the book that, I don't know if you can show you. This is the book I wrote for WHO in collaboration with WHO in 1995. I think, Patricia, your name is mentioned also in this book because you helped us developing the guidelines that we use for 20 years for the WHO. So all these factors are important. Then we have ototoxic drugs, a very common problem in Pakistan, India, ototoxic drugs, very common process. And I come from that generation where TB was common and they used to use streptomycin, etc. And nobody knew those. Of course, the important thing was to save life rather than the ear. So they all had problems with tinnitus and hearing loss, etc. But in later days, we had other problems like viral infections and these, which experts will tell us. The impact of hearing loss and deafness is multifactorial. communication problems, speech, cognition, education, employment, social isolation, and DALIs and quality. This is the word that I learned from WHO when I was a consultant to them, but now I use it regularly because as we're compiling an encyclopedia of Islamic medical ethics, this word keeps coming all the time, that how you calculate the quality adjusted life years and disabilities adjusted life years. Because what is important, ethical dilemma, that if you have X number of equipment like hearing aids available, who should you give first? Those who are more productive to the society, or on the basis of judgment, equality, equity, and what is it's called uniform distribution of resources. That's an ethical dilemma that I'll briefly talk about if we get a chance. But this is important. What is also important is that we should remember the quality of life is important. If you want to rehabilitate the person, to improve the quality of life. Because I know somebody who lives in my neighborhood in Wimbledon, he sometimes when I go to see him, he can hardly hear me. And doesn't want to wear the hearing aids because it's like a stigma for him. He says, people who say that I'm hearing impaired or deaf, etc. Now, these are the problems. Now, we can prevent a lot of conditions. There's been a lot of problems with immunization in the recent past. A famous report that was published by a gentleman, I think it was named Andrew Brake or Andrew Bickerman, who published that there was connection or some kind of spillover from vaccination on to autism, like mumps, measles, etc. And a lot of people stopped vaccinating their children. Recently also, there was a talk on Radio 4, whether immunization, how do you improve the immunization? Because a lot of children are getting measles in the UK. And of course, you people can tell us more about it. Now, I'd like to mention that immunization against COVID, which has been recently, and I saw, I'm sure you must have seen patients who came with hearing loss. In fact, I had the other day, some gentleman came to see me because he's got tinnitus, vertigo, and hearing loss following the COVID vaccination. And this is something which we have to discuss. Then you have other questions like genetic noise control, I think is an important factor. And thank goodness after the WHO report, which was published in 1905 or something, guidelines, there has been some degree of, at least in these countries, but of course, noise in Pakistan, India, Bangladesh, Malaysia, etc., is still quite troublesome. It's not just a question of hearing loss, but also they develop tinnitus, and they also develop suicidal tendencies, etc. Now, rehabilitation, hearing aids, and amplification devices, which you will tell us what are available, and of course, the miracle that I call the miracle of modern science is cochlear implants. I remember way back in 1994 or 95, Dr. Beg, who was my very close friend, he was the ENT surgeon of great repute in Pakistan. He brought over two persons for an annual conference, John Graham and Graham Fraser. I still remember the name. They had started working on cochlear implants before we imported somebody from India, can't remember his name, and he demonstrated cochlear implants in 1999. We did the cochlear implant first on, experimental, and it was a demonstration on a cadaver in 2000 when I was still there in Karachi, and then I left. Since then, people have taken over. Of course, Harun is running a project in the name of IMRA. He'll tell us more about it. Naveed and his team, they go regularly to Pakistan. We'd like to know about cochlear implants. Farooq is also doing in Pakistan, so we'd like to learn from them. And of course, the emerging technologies which we'd like to learn from Naveed. He's an expert on implantable brain devices and things, and what is happening in the future trends. And I'd like to thank you here. I'd just like to show you this. This is the work we've been doing for the last 2, 3, 4 years through Sadiq International, which only this morning we had to finalize the cover page. It's not out yet. It's in the press. It's running. This is what we've done on behalf of Sadiq International Virtual University. Shahid is my associate as always. And we have Sholeh Bikli from Iran and Tabassum Zahra from the Aga Khan University. This book will be out shortly. It's literally in the printing press at this stage. So over to you, and I'll finish my talk and stop share. And then I'll ask, I think we'll ask who will start. Patricia, are you ready to start? Would you like to talk first?
Yes, I'm ready. Patricia Castellanos, audiology audiologist from Guatemala, and I live and work here in Guatemala City. My specialty is I have a master's degree on education of hearing impaired people and my doctorate in audiology. So this is the topic that I was asked for. Next, please. Next slide. Okay. As Dr. Zaidi mentioned, WHO has done a lot of research and writing on all these technologies, hearing loss, etc. So it is estimated that 217 million people in our region. When I address to our region, I'll talk about America, Latin America. They all have some degree of hearing loss. The need for ear and hearing care is growing tremendously, and the gap between the need and the access can reach up to 83%. This is according to WHO. So as always in all the low and middle income countries, this is the huge problem, the main problem. Next. So this is Latin America, and also WHO estimated that there is a $262 billion of dollars is estimated to be the cost of untreated hearing loss. So this is a huge amount of money, especially when we think about the countries that we live in, where the needs are tremendous. Next, please. So we held an international meeting in Panama just this last February, and most of the information I will provide was collected through these countries. There were 20 countries from Latin America represented there. So regarding national hearing screening, only 14 countries have at least one program. Some of them are private, some of them are public, but there's only, in most of them, only one or two programs. 5 countries screen only high-risk babies. You know that, well, the high-risk problems you already know, but it is risky to do this because we know that 50% of the kids, of the babies who are born with hearing loss have high risk factors. The others don't. So we lose many of them when we do this type of screening. 13 countries have laws for neonatal hearing screening. So that means that, for instance, in Guatemala, we do not have a law, but I started this program a long time, well, I would say a long time ago, but actually working, we started about 6 years ago. But we don't have a law. So my foundation is the one that's leading this campaign and this program in the major public hospitals. National programs for ear and hearing care, only 5 of the 20 countries have one. So as you can see, this is not a priority for the governments. Human resources, 7 countries have some type of audiology training programs. Some are master's degree, others is just a diploma, very different levels, but only 7 countries. So the lack of audiology in our region is tremendous. 13 countries have ENT training program. So the people have to travel abroad to get training. And again, we come to the economical side of this issue. And that's the same problem with audiology. In audiology, people, if you want to become an audiologist, you have to travel, and that the cost of that is tremendous. 2 of the countries offer audiology assistant programs, which has been handy in some of these programs, in some of these countries, I'm sorry, because of the lack of resources. Next, please. So Now I will talk about these four topics but focusing on the challenges we have in Latin America. Next. Next, okay. So the medical challenges, as mentioned earlier, there are very few ENTs, few or no ENTs in rural communities. So for instance, in my country and in many countries in Latin America, we will have, if there are 20 ENTs, they're all in the capital city, but there are no in the rural communities. So that's a huge challenge for the people who live outside the city. Few ENTs are able to perform ear surgeries, like the ones I'm mentioning there. General practitioners have very little knowledge on ear and hearing care and hearing loss. So they won't be able to early referral for diagnosis, counseling, or any of these topics. Little knowledge of management of hearing loss, as I said before. Oftentimes, quality services and treatment are provided in the private sector. So people with no funding in let's say the government, if there are some countries whose government provides sometimes of some type of services, and so they're free. But most of the people with no good income will have to go there, and usually the services in the private sectors they are not qualified enough, and they do not provide the state-of-the-art management, treatment, technology, etc. Next. Audiology has the same problems. Few or no audiologists in Guatemala. There's only me, for instance, for 16 million people. And that's the case in many countries in this region. Few clinics are able to test babies and young children. That is a huge problem, because then sometimes you come across a family that brings the baby or brings the kid because they say that they believe the kids are not listening, but then someone who can test the very young kids, I'm talking about 2-3-year-old kids, is not reliable. So that's a huge problem also, because then sometimes the treatment is given at the treatment, audiological treatment, meaning cochlear implants, hearing aids, are given with a non-reliable test. Few trained technicians and speech language pathologists. In our region, we cannot distribute several brands. For instance, if I want to sell hearing aids, I have to decide on one brand. And if they want to give us the brand, then we have to sign a contract, meaning we are not going to sell any other brand, which to me, it's unethical. But anyway, that's the way it is. And it's the same with cochlear implants. So the families do not have a choice of which brand they would like to have their kid fitted with, but they are married to the brand that, for instance, in Guatemala, that I distribute. But I tried, and I had almost a legal problem because I was using two brands. So to me, that's unethical, but that's the way it is. Very little countries have protocols for selection and management of users of various devices, for instance, the cochlear implants. Most of the time, there is no neonatal hearing screening in the country. So diagnosis is done very late in life, when the parents realize that the kid really doesn't speak at all. Next. In terms of human resources, very few training programs in the area for audiology, for speech language therapists. Also, the information that we can get, most of it is in English, and English is not the first language in our country, so that is a problem. insufficient ENTs, audiologists, and speech therapists for the amount of people living in each city, insufficient technicians or doctors to perform reliable audiological tests in babies and small children. We talked about that already. Next. The economical challenges, well, every country faces them, but low and middle income countries, it's really bad. The cost of the devices, the hearing aids, for instance, in Guatemala, to have a private, reliable ABR will be the cost of one salary. So for many people, I mean, not for everybody, but for many people. So either they eat or they do the test. So that's a big issue. The cost of private services. So if they want to come to my private practice, then they have to collect money for several months in order to do a private practice ABR, any hearing test, or not even saying the hearing aids. And if we want to send someone abroad, that is just a huge amount of money. So in this meeting, we came up to specific priorities that we would like to address in the following 2 years. The first one is to integrate an ear and hearing care program into primary care, strengthening effective care and intervention, because it's not only important to know what causes the problem, but then how to manage it. Train primary care workers and hearing screening throughout life course. So it's not only kids, but it's also older adults. Increase and strengthen hearing screening outreach throughout the life course. So what I mean by this is that many governments say, okay, let's work with babies, but then they also forget about older adults, which is a huge number. I would say the largest number of hearing loss is there. So that is something we want to address. And then use of the different tools that WHO provides us in order to understand what's going on in our countries and be able to plan accordingly. Next. So this is just a very brief X-ray of what's going on in our regions. But I would say I could also almost guess that this is the reality for many other countries in the other regions too. So thank you very much for listening, and hope everything goes well today.
Go ahead. Invite Shahid.
Well, I just want to make a comment. I think the talk with Dr. Patricia Monez was lots of things that have come up, and it's really interesting to hear you say that. The first thing that struck me was the lack of audiologists. And of course, we can't have any level of ear surgery, really, or advanced ear surgery, certainly, without the help of audiologists. So that limits the type of surgery that can be done by ENT surgeons. And also, secondly, the brand monopoly. I mean, you pointed out the ethical issue. This is a serious ethical issue, and I think this should be tackled in a world situation, not just for Latin America. This is not a good policy. And certainly, all medical journals have spoken against this. This is well recognized. And the lack of neonatal hearing loss. I think these are all important issues you raised, and we'll discuss it further. I just wanted to make these points to say how useful your talk was. Thank you so much.
Prof. Muzammil, and thank you, organizers, for putting me to this workshop with the elite otologists and audiologists all over the world dealing with hearing impairment and the cochlear implant. And let me have a confess here. My story of landing in Malaysia almost, and by the way, I have put here my current status that I'm working with the American institution, American University of Barbados School of Medicine currently, but my entire experience working last 25 years has been in Malaysia. And the confession that I want to make is that when I landed in Malaysia 25 years back, I was trained otologist and I was appointed with that understanding. But within a year of my landing, I was asked to develop head and neck and thyroid surgery within the fold of ENT, which didn't exist at that time. ENT was practiced as ENT. So I moved over and I never looked back. But what was very close to my heart was the otology. But anyway, you know, in service, you can be assigned any task to do. Then Professor Zaidi invited me for this forum, and despite of my very heavy commitment of undergoing accreditation right now, I spared some time and I'm sharing my experience, which will be purely the experience of hearing impairment and the cochlear implant in Malaysia. I'll not take time on this. Prof. Zaidi and Patricia has talked in detail about the concerns that Malaysia has about the deafness is not different from the rest of the world. Is the causes may include genetic infection, noise-induced aging, and not to forget consanguinity and ototoxicity. But I didn't put it here in Malaysian scenario because these two are not the real problems of hearing impairment in Malaysian perspective, because cousins marriages are hardly seen here. Over 40,000 deaf, legal deaf living in Malaysia, and demographic, and the number may increase manifold. Demographic variation among the hearing impairment has been predominantly age, gender, and ethnicity. And looking at the cochlear implants, how it helps individuals with severe to profound hearing loss in Malaysian scenario, the adaptation and practice of the cochlear implant in Malaysia dependent on a number of factors, which include healthcare infrastructure, awareness, accessibility, cultural attitudes towards hearing loss, and the assistive technologies. Some challenges, however, we faced in Malaysia, particularly the team engaged with hearing impairment and cochlear implant and management of the hearing loss in terms of rehab, was the cost of the implant, access to specialized medical professionals, need for ongoing rehabilitation, and supportive practice. In Malaysian scenario, children with the cochlear implant have reported an improvement in overall speech intelligibility. Children using cochlear implants have reported to show a definite improvement in mood and overall emotional well-being. That was something very important for the parents as well as for the children themselves. Better hearing and speech development and returning to the normal classroom was another achievement, and better perception of those having sound issues for their personal safety was improved. Cochlear implant program in Malaysia is run both in public and the private sector. Having the cochlear implant practice started since 1995, it greatly enhanced auditory performance as compared to the hearing aids. And University Science Malaysia, University Kebangsaan Malaysia, UKM, which pioneered in cochlear implant the initiative was taken in 1995 in the Southeast Asian region. And the long-term outcome of the UKM predictors, I would say, in terms of proportion of the children who were implanted and still using device, I'll share that with you in a moment. Next slide. Children's modes of communication and their educational placements and their functional auditory and the oral performances. So sharing that data here, among the implantees, 97.6% are still using their cochlear implants, which is encouraging. 69.8% communicating orally, and 58.5% attending the mainstream education. Also very encouraging. Logistic regression analysis shows of a study that age of implantation reliability predicts implantees' rehabilitation benefits particularly predominantly in children. So UKM Cochlear Implant Program has achieved reasonable success among the pediatric implantees. The Cochlear Implant Service operational policy was established in Ministry of Health, Government of Malaysia in 2009, though the practice started from UKM, the University Hospital, in 1995. The document of this policy outlines optimal achievable standards in accordance with the best practices and guidelines. And then this used as the best practice standard for all the related professionals in cochlear implant management. The document is reviewed periodically, I suppose every 3 years or whenever it is needed. Ensures the cochlear implant program is carried out safely, effectively, and promptly. Now I'll share one of the studies from the government sector published, include some of my students at that time. There were students like Rajan and Tenku and Zulkifli, and of course Siti Sabza, which was my colleague at that time, and she is still practicing ENT there. So I'll share some of those findings from their study of the 5-year experience at the government level of the cochlear implant. The postlingual patients implant with the cochlear implant under the National Ministry of Health Cochlear Implant Program between 2009 to 2013. 41 postlingual and 15 crossover patients were implanted between 2009 and 2013. The age of implantees ranged from 3.6 years to 63.2 years old, and resulted with only 2 complications, which was 3.6% of all the implants done. And among these 2, a case of electrode migration at 3 months post-implantation and 6 months post-second implantation was reported, and another was a case of device failure at about 1 year post-implantation, and both of these patients were re-implanted and are doing well. Then I'll be failing in my duty and delivery of this if I do not mention the private sector contribution to hearing impairment management and cochlear implant. And leading a hospital or institution, I would say, the Sunway Medical Center has the longest running cochlear implant program in private sector, initiated 2004. Its speech hearing center is designed an integrated department to better cater for the cochlear implant and rehabilitation of the hearing impaired. And they are actively using implants in the major cochlear implant brands. All 3 types have been used: Advanced, Bionics, Cochlear, Americas, and Med-El, providing patients with more choices. We understand that and just my concluding remarks, that we understand that having the cochlear implant will be a lifelong commitment for all engaged health professionals in hearing impairment and rehabilitation services, not only in Malaysia, but globally across the board. This is the operational policy, written, documented, and published July 2009, with the rehab of the profound deafness and cochlear implant. And my last remarks before I say thank you for having me here is that the achievement of the cochlear implant effectiveness would be when our children stop talking in sign language. With this, I thank you very much.
Okay, thank you very much for giving me this opportunity to speak in this forum. My talk will be about our journey in the field of audiology. And I titled my presentation as Dream Big. I really will concentrate on some positive aspects in our situation. Although there are a lot of challenges, I think most of our challenge addressed by one of my colleagues, Dr. Patricia, because we have a similar similar community and similar challenge. Yeah. So I will concentrate only on some positive points of our situation. I am a citizen from Najaf city, which is situated in the middle of Iraq. It is about Harvard 2 million population, and I took this information about the live birth rates annually in my citizen is 50,000. And of course, when we speak about live birth, already all of you think about neonatal hearing screening. And unfortunately, in my city, there is no established neonatal hearing screening. Only in the capital of Iraq, Baghdad, there is a pilot study and a pilot experience to start neonatal hearing screening. And also, I know in the Karbala. Yeah. In our city, we have 5 audiologists and me. One is master degree, other is diploma, other are practicing general practitioners. We did a lot of services to help people with hearing impairments. We are working in both public hospitals and private sectors. Actually, we provide mostly in our public hospitals behavioral tests, mainly pure tone audiometry and tympanometry. And unfortunately, currently, we don't have physiological tests or ABR in our public hospital, only in a private section. Our journey with audiology, although I am a ENTist, get my Iraqi board at 2006, but I dedicated my career for audiology and vestibular medicine. So what we did, firstly, we established a hearing and communication disorder clinic at one of the public hospital in Najaf, which is Al-Furat Al-Awsat Teaching Hospital. And we provide mainly speech therapy services because we, till now, we didn't get the required equipment to run an audiology test. Audiology tests usually run in other hospitals, but we provide a speech therapy services by trained staff, and I lead the team. We have about 600 registered patients, mainly kids, and we have all the data of these patients recorded electronically, and we have their contact phone numbers. And our plan is to initiate a state-of-art center for audiovestibular medicine, and we are currently working on that project. And there is a place in this hospital designated for this center. But I have to mention that we regard it as a center of coordinating services between all the hospitals, and to follow the patient. We also receive the patient from primary healthcare centers, and we provide guidance and education and registration, even for people with hearing impairment, and we guide them, because this is a real problem in our community. Sometimes the patient lost, or they don't know where he go, or what is the proper time of seeking medical care. So we provide guidance, support, education, and coordination of hearing and ear care services all over our city. What actually did in the last few years, we disseminate the knowledge and education among our community regarding the ear and hearing care through formal meeting with people, especially in collaboration with social centers. This is a picture from Al-Zahra Social Center, where we are delivering a simple language lecture and responding and answering the participants' questions and concerns. Also, we are utilizing the media whether radio stations or TV stations, to disseminate knowledge about the hearing and ear care and services, and also answering the people questions. Sorry, is my voice is clear? Sorry.
Yes, Al Habib, your voice is clear.
Okay,
Yes.
okay.
It's very clear.
Slides are stuck.
Slides are fine.
Are stuck. I don't know. Just I have slide is stuck.
Yeah, please go ahead. You're fine.
Yeah. I have a little problem. My slides are stuck, are not moving. Please, Doctor. Yeah, and maybe due to some internet connection problems. Yeah. Dr. Mubashir, can you run the presentation from your side, please? Can you run the presentation? Because my slides are not
have your
moving.
slides.
Yeah,
I don't have your
I
slides.
think my slides are not moving. Yeah, are not changing.
Yeah, you can restart. Stop sharing and then share again.
Mhm.
Dr. Habib, unshare and then reshare.
Yeah. I
Yes.
think okay.
Yeah,
I think okay. Okay. When another point, we are working with the primary healthcare department, public health department, to train to do multiple workshops for primary care doctors and also for the nursing staff about the hearing and ear disorders in collaboration with the Department of Public Health. This is a very important point. We educate our colleagues. We try to send a message that we are one team working together in a coordinated manner to achieve a continuity of care. Is very important, and we have a good collaboration with the primary healthcare centers. Actually, we are working through a referral system. We have to work to enhance the referral system, and we go in good steps in this system. And also we are working as a part of early childhood development program. It is one of the programs run by the Department of Public Health, and we activate the hearing part of this program. So this is to achieve continuity of care and to link between the primary healthcare and secondary care in the hospital. And as I mentioned, our hospital, Al Farad Teaching Hospital, act as a hub to coordinate the service between about 50 primary health centers distributed all over my city with the main secondary care services, which are the hospitals. International collaboration, we are, alhamdulillah, work with WHO, especially the Professor Shili Chada, which is the leader of Deafness and Blindness Prevention Program, with the help of Professor Shabir. He is my mentor, and always he supports us and inspire us and encourage us to expand our collaboration and networking. Collaboration with the WHO ended with recognition and designation of Kufa University Medical College as one of the collaborative centers for WHO hearing services. And we are actively participating in most of the activities set by WHO, like the World Hearing Day, which will be every year at 3rd of March every year. And we disseminate the information and the educational material provided by WHO to our colleagues and our community. We also have the opportunities to work with Imamiya Medic International and Global Kindness Foundation, who visited Iraq many times, and we participated in screening of orphans and primary school children. Also, I have to mention the support of Professor Riaz Sidqi, who supply our college with audiological equipment and hearing aid, and he was very generous, and he was ready to answer all my questions, and he supported us during this journey. From academic-wise, we recruit a team of researchers, both nationally and internationally, and did many research. One of them, as displayed in this slide, is a novel research in my country. We studied the gene responsible for mutation or severe to profound hearing loss, congenital hereditary hearing loss in our population. This is done with basic scientists in my college, and it is published in one of the Scopus Index journal. It was very great experience for all of us. Currently we have about to establish a master degree of audiology at Kufa Medical College. And I have to mention that a similar program initiated this year, already initiated in Baghdad, in Al-Mustansariya University. So in summary, we have to think big, dream big, and believe big, and the result will be big. In spite of our challenge, in spite of limitation of resources, we try to do our best in order to serve our community and improve their health. And thank you very much.
I invite Dr. Riaz Ahmed Siddiqui, consultant audiologist from Birmingham.
Thank you. Thank you for introducing me third time. I'm feeling a bit proud. First, Dr. Hassan, Shahid Hassan said me a professor. Now, so I've been a slide for saying professor. I am the one who started the audiological, provided the equipment from the UK in the Kufa University Hospital where he's working. And he have many questions. I have made a presentation answering most of his questions he was asking on telephone day by day. Right. So coming back on this, management of hearing impairment in the UK, it started from the day one in the UK, on the day of the childbirth and the most of the cases. So if the baby is not contraindicated, like any atresia, any microtia, bacterial meningitis, or cytomegalovirus, he's being screened on the first day in the hospital. Now, this is what we are seeing on the screen is the NHS flow chart. That on the first day, baby is being investigated or screened through auto-assisted emission. If it's gone okay, it's okay. Otherwise, it has been red flagged and referred to the other service within a month with for gestational period of 40 weeks. He has to come and go through the auto. Let me do it a slide bigger. Oh, now go back on second. This one. Better not to touch it. So go through the auto-emitted ABR. If it's failed, it is referred. He is referred to the audiological services. Go to the third one. Now, when it's reached the audiology services, they have to follow a battery. In the first week, that was done. Autoacoustic emission is being failed. Tympanogram, not with the normal adult 2 to 6 frequency, but the tone hertz is used 1000 hertz. AABR, if not done, screening again. If contraindicated anything, referral to the ENT and neuro-otology. In the audiology clinic, very important things. This is first, audiological person is the first person who has been doing this test battery and the first clinical person. Now in the case history, we are obtaining him the parent's history, primary caregiver history, any of the other social conditions, any relevant medical or development history, including prenatal and perinatal, any previous hearing screening results if they are on file, development of motor, cognitive, and visual vision skills, emerging communications, milestones, including any receptive and expressive speech and language, parent caregiver's judgment regarding responsiveness to sound in his own environment. Infection control, we all have a good practice in the COVID days. So especially in the child case, cleaning hands, cleaning this, and then disinfecting any of the equipment which come in contact with the baby's body or in the ears. Otoscopy, Dr. Sohaib was asking a few things what to do, which is equipment, so the devices should be used. Most of the cases, audiologist again is the first clinical person coming in direct contact. So not only otoscopy, he should examine the outer ear for any malformations, outer and inner side, back side of the pinna. Any malformations should be noted, listed, position of the head, position of the ears on the head is, for example, any asymmetry, any part of the pinna is missing, look for any lesions of the cysts. If any condition found, refer to the ENT. Now, the placement of the probes insert using during the testing should be done very carefully. If any obstruction in the external auditory canal, such as excessive wax or growth or foreign body, especially in the cases of the newborn 1 or 2 days, examine the presence of vernix inside the auditory canal that may affect the result. Now in the audiology, if the infant is there, aged between 0 to 6 months, first test is done is the behavioral observation assessment. Simple, baby is sitting in the mom's lap, and the audiology examiner is sitting in front, and someone is trying to distract him and noting his response. When he reached to the age of 5 to 24 years, visual response audiometry, again a procedure using with the test is suitable for the infants of 6 months to 2 years. If successful, you can measure the level of the child's hearing across the speech frequencies. That is helpful in deciding the application if decided for the hearing aids. Play audiometry is again the next procedure between 2 to 5 years with the child development, cognitive and linguistic levels, visual and motor development, and ability to respond appropriately. More specific behavioral information can be obtained as the increasing age. If it's diagnosed as any hearing impairment, pathology access to amplification, bilateral sensorineural hearing losses, especially in the UK, they are sent to the ENT, CT, MRI, ENT have to decide, refer to cardiology for Gerber-Nelson syndrome, cochlear implant team, if it is a very severe bilateral hearing loss, if it is genetic finding, Down syndrome, Waardenburg, psychological assessment, and to genetics. Assess the need of the patient. Is he need to be referred to any other services, ENT, speech language therapist, social services, special needs in the school or anything. Psychological assessments, including acoustic emittance, tympanometry, they are being done when the child is going through the behavioral observation, and the other pediatric audiometry. Autoacoustic emission, automated distortion is the first test. If it failed, it has to be repeated after a few months. Electrophysiological audiometry, including AVR, cochlear and retrocochlear information, wave 1 and 2 originating from the distal and proximal auditory nerve fiber, wave 3 from the cochlear nucleus, and wave 4 showing activity in the superior olivary complex, and the wave 5 is also studied for the lateral lemniscus. Problem with the dealing with the children is difficult. Sometimes they comes up with the most of the time they do it like this, and you have to wait. A lot of time is wasted. Now, coming quickly to the management of the adult hearing loss in the UK again. It's again the history we have discussed above, some ear infections, occupational history or any trauma history, examination, otoscopy we had discussed above. But now he may have some perforations or anything. Rennie's, now audiologists usually don't do this, but they are very informative. Rennie's and Weber test. Sorry, my screen is stuck somewhere. No, coming back. Okay, coming back to the Rennie's, they are very authentic, in use more than 100 years. Now, in the diagnosis you are making in the adult hearing clinic, conductive for the middle ear infection, ossicular disease should be referred back to the ENT people. Sensorineural senile presbyocusis audiometric finding, they are always bilateral, almost symmetrical, sloping on the high frequencies, noise induced showing notches 3 to 6 kHz, traumatic, unilateral, maybe a result of road traffic accidents. Meanies, low frequency reverse slope, refer back to the ENT. And for the opinion again, if they still think they will be benefited with the hearing aids, then we have to do that. Pure tone audiometry is the main test is done to assess the sensory hearing in the old age. The test requirements will be comfortable environmental, no activity, strictly under the British Society of Audiology's guideline. Calibration of audiometers, daily check, monthly check, oral calibration should be done. Any faults should be reported. Ambient noise level ideally should be about 20 dB. Now, with the advent of the computers, new technology totally changed the audiology assessment all over the world, also in the UK. And the rehabilitation with the hearing aids has also changed from linear to digital. First, digital hearing aids produced by Oticon in 1995. In the UK, Department of the Health introduced MHAS, the modernization of the hearing aid services program, in 2000. So started only with 20 hospitals in the first wave. Other hospitals were included after 2005. Hearing assessment, hearing aid selection, programming, and fitting become easier, close to the target, and listening comfort for the patients with the comfort of the digital signal processing. In 2003, a study was conducted that identified the difference of the gain prescribed in the hearing aid software and output of the hearing aid. It was mentioned about 30 dB. It was a great difference, providing the hearing aid amplification at the target. The verification of the digital signal processing made compulsory in the UK by real ear measurements. It helps to program the aid plus minus 3 to 5 or 3 to 8 dB in the worst cases, thus provides more speech clarity. That the hearing aid technology nowadays is also working other than the loudness on the speech clarity, compression of the noisy background, that means to suppress the feedback, and elimination of any other artifact. So that's the brief description of what we are doing in the UK for the hearing aids. Hello.
Our next speaker is Dr. Harun Zafrullah Khan, and many of us know Harun Khan, who is the idea and the chairman of the IMRA charity. And this charity is well known for its welfare work and for cochlear implants in developing countries. And I have personal knowledge of people who have worked with him and of him. And the program has been very successful in many parts of Pakistan, particularly in Sindh. Dr. Harun is a consultant otolaryngologist in Manchester and is a well-recognized member of the community. Dr. Harun Khan.
Thank you very much. I am trying to get my screen. Am I on the screen? Okay, can you see me now? Okay.
We can see you perfectly.
Okay, thank you very much. Sorry, I'm not so much good at technology. But first of all, I would like to thank Professor Shabi Zaidi for arranging this very important topic. And also welcome to all the esteemed panel, and thank you, Mushir, for the introduction. And
Sir, can you bring your camera to your face? Because we are, can you bring your camera to your face? Okay, yes, sir. Fine, sir. It is fine, sir. Thank you.
Okay, and finally, thanks to all the listeners, who are waiting patiently and listening. Most of the things that I probably wanted to say, most of it have been said already, so I don't want to repeat, but I would like to speak in the context of my experience as being introduced by Professor Mushir, because most of it applies to low and middle income countries. But in the context of the topic, globally, some of it has been mentioned that nearly 400 plus million people are suffering from some sort of hearing loss, which we call disabling. And then in 25 years' time, 1 in 4 people will be having some sort of hearing loss, which will affect them a lot. So that's technically 80% of these people will be in low and middle income countries, which is Pakistan is a part of these middle income countries. So and as spoken by as mentioned by other speakers from Iraq and Guatemala, all these figures and numbers apply to most of us. Now, obviously, Riyaz Siddiqui touched on the detection of hearing, so I don't want to go into much details about these things. And what I would like to talk a bit about, the impact, and then my involvement with the hearing impairment. So the impact is tremendous, as we all know. I mean, I don't want to go into the details of the impact, but if I apply this to Pakistan, if a child is totally deaf, then the whole family is affected, because he can't hear anything. Somebody has to be looking after him. So it actually impacts the whole family. And if we can alleviate his hearing, then he becomes a part and parcel and contributes to the society. So that is what is something that we can help with. So my other mention about is the involvement of my charity in dealing with hearing impairment. So IMRA is an international medical relief agency registered in UK, Pakistan, America. Twice winners of BMA Humanitarian Award for its work in Pakistan, which is a very difficult to get. There are 400 applicants every year, and we have won this award twice. And I have also charity being registered with WHO. I have attended Deafness Forum several years ago in Geneva as well on behalf of the charity. Now, coming to the global perspective, so as I explained, most of it has been touched, all the problems that face, the shortage of audiologists, training, teaching, and investigating. So I don't want to go into much details about that again. Now, what I want to touch a bit about, why is it important, as mentioned, but it is important because most 60% of this deafness, starting from children to adults, is I would call irreversible. So if we have a proper good screening program, some of these children can be diagnosed early and treated accordingly, and not wait until they are 15, 20-year-old and then they are burdened to the society. And then coming to noise exposure, as explained earlier, they in low and middle income countries, it's a potential problem which is being addressed, but WHO is trying to emphasize on this and spending a lot of money and providing support both in terms of manpower, information, data, as well as probably financially, because I know that WHO had given a lot of money to a country like Pakistan to deal with deafness in the past. And so all these things are technically, as I said, irreversible, in the sense that if it detected early, some of these serious consequences can be avoided. Hearing aids, which is a very, very costly in these low and middle income countries, very difficult to get good quality hearing aids. So some of these things can be addressed. I was listening to, only last week there was a seminar by ENT UK and global health, and I've gathered that Warwick University has been working on producing a very, very low priced hearing aid, which I think will be available soon. So I have to try and get more information about this. So prevention side, as I mentioned earlier, a lot of people have covered all this. I don't want to go into much details. Now, from IMRA point of view, what we have done is in the last 15 years, we have embarked on a program which we deal with middle ear surgery. And we have done over 650 middle ear cases in province of Sindh. So every year our team goes out, most of them from UK, and we operate on people who are not even seen an ENT doctor. They come from hundreds of miles and they get operated by top quality ENT surgeons from UK. At the same time, we are teaching and training people in Pakistan to learn ear surgery. In the last couple of years, we have started, training through a screen, so people who can't be in theaters, can't have too many people, they are watching on a screen. So this as an added facility. This same program is being conducted in Karachi for poor patients, and the last 5-6 years. So this is middle ear surgery. We also give a lot of free hearing aids to people who are deaf without charging anything, because it's a charitable organization. And finally, you'll be hearing from Professor or Dr. Naveed Ahmed, who is a cochlear implant surgeon of our cochlear implant program. Obviously, cochlear implant program is I would say, or cochlear implant is an ingenious technology of the 21st century. A deaf child, completely deaf, can learn to speak normally. It is a gift. And we provide this gift of speech and hearing in Pakistan free to people who can't afford. An average price or cost of an implant in Pakistan, if somebody goes privately, is about $25,000 to $30,000 nowadays. An average annual income of people, if it works out according to some of the WHO estimates, is about $1,000 annually. This is annual, so you can understand how poor people are and who cannot afford cochlear implants. So we provide this free for people, and we have, and until last August, we have done over 135 children and free implants, and most of them are able to speak and are in the speech therapy and rehabilitation. So I just wanted to touch a bit about these things. Obviously, WHO has been pushing a lot, on this deafness, and guiding in member states. And every year they do a World Hearing Day, so people do lots of activities. So I don't think there's anything more for me to add just on this topic, so I just wanted to contribute a bit. Finally, I would like to thank all of you for listening, and I'm sorry I didn't prepare any slides, but I think it is equally good to talk. So I would leave it now to the other speakers to finalize, and then we're happy to take any questions. Thank you very much.
Thank you, Dr. Harun Khan. I mean, the absence of slide was not felt. I think you spoke very well, and we could all hear you. Thank you for your contribution. Our next speaker, and I think the last speaker for this discussion, is Dr. Naveed Ahmed. I can't see him just yet. His name is there. Dr. Naveed Ahmed, are you there?
Yes, I'm here.
Can we see you?
Yeah, let me just turn my video on. Is that
There you
working?
are, yes.
Working,
Dr.
yeah.
Naveed Ahmed is super specialist in a way. He's the implant surgeon, cochlear implant and other implants, and he works at the James Cook University Hospital. And that hospital in the UK has had a big reputation for otology services for a very long time. It has had lots of quite well-known otologists, Hawthorne, Flood, and now Banerjee and Naveed Ahmed. They're all there. So this is a famous pedigree in the department. They started cochlear implant very early in the 1990s. So it's a well-established department. Please go ahead, Dr. Naveed Ahmed.
Okay, let me just see if we can share the screen with you. Let's just see. Play from start. Are you all able to see that? Yeah?
Yes, yes.
Oh, fantastic. Excellent. Well, thank you very much for that lovely introduction. And I would say that when you mentioned my mentors, Mr. Hawthorne, Mr. Flood, certainly brought a smile to my face. My first ever implant was done with Mr. Hawthorne. So I have had the great privilege to be invited to be presenting to this august group of professionals. I am trained within the UK as a specialist, but then I went abroad to a number of institutions, most recently to Stanford, to supplement my training in neurotology and skull-base surgery. I also have the great privilege of being the director of the IMRA Charity Cochlear Implant Program, and the audiologist who presented certainly made me feel very happy, because I was fortunate enough to do a master's in audiology from University College London. So I like to look at treatment of hearing from both perspectives, not just from the surgical, but the audiological perspective. And in many ways, in cochlear implantation, this is very much a multidisciplinary team effort. It's not just about the surgery. It's not just about the implantation. So let me just see if we can move to the next slide. Are you able to see the next slide? Yeah.
Yes, we can.
Yeah, brilliant. Okay. So very briefly, I'm going to talk about what a cochlear implant is, the surgical technique involved, how they came about in the past, current trends, and then really future access. So I have been asked to talk about these things, and I would say it's quite a challenge to cover it all in the next 25 minutes, but let's see where we get to. So in terms of context, it's already been covered. With severe to profound hearing losses, better than a hearing aid is really a cochlear implant. Within the UK, 1 in 1,000 children will be born with that level or a profound level of hearing loss. But in Pakistan, as was earlier mentioned on consanguinity, we're looking closer to nearly double that figure, 1.6 to 2, as the Ilahi et al. Paper suggests. Another key factor when it comes to cochlear implantation, which isn't often appreciated, is that there is a critical age to intervene. So, if a child is born deaf and then they present to you quite late, as unfortunately we've found in developing countries, sometimes that window of opportunity to intervene and make a lifelong difference, that window of opportunity has been lost because they came to you when they were 6, 7, 8, 9, 10. So that's why I would say a newborn hearing screening program is absolutely essential, whether it's in one hospital or it's universal, like across the UK and the NHS. These are all very important factors when it comes to not just for cochlear implantation in general, but any hearing loss intervention, and that includes hearing aids. So the earlier these children are picked up, the quicker they can be treated, and then the better the auditory cortex will be stimulated, and therefore the speech development can then accrue. So as mentioned, that kind of level of hearing loss, a hearing aid is very unlikely to benefit this patient, especially when it comes to the higher frequencies and the consonants that are important in speech discrimination. And that's where cochlear implantation comes in. So what is a cochlear implant? It's a surgically implanted medical device which electrically stimulates the remaining neural fibers of the auditory nerve. So that current from each electrode stimulates the remaining spiral ganglion cells to generate sensations of hearing. So in the same way, you will have an electrical impulse going down from the cochlea to the spiral ganglion cells. What we're essentially trying to do is mimic those signals so that the brain perceives something as sound. So you can see here just some very brief animations. Essentially, you're trying to generate an electrical current so as to stimulate those spiral ganglion cells. But you've got to get that electrode into the cochlea. So the wonderful anatomical luck or fortune, you could say, that we have is that we have a cochlea which has tonotopicity. So the length of the cochlea and where the stimulation occurs denotes the frequency that the brain perceives. If that wasn't the case, I can tell you cochlear implantation would be orders of magnitude more difficult. So we were very fortunate that our creator decided to make the cochlea in this particular fashion. So then, as you can see, in the gray is the electrode receiver coil, which all is implanted. It's not visible. And then the bit that's visible is the transmitter coil and the speech processor and the microphone. And this also provides power to the internal component. So there's no battery inside the cochlear implant. The battery is external and it's powered through radio frequency. So what are the potentials of CI? Well, firstly, the key one is that you have access to sounds ranging from environmental through to speech sounds and even soft sounds. So you will often find patients saying, oh, since my cochlear implant, I can hear the birds. Since I've got this cochlear implant, I can hear quieter sounds. The key thing in children is the development of speech. That's absolutely essential because speech and language is what helps them become members and contributing members of society. So what does a cochlear implant do? Well, if your hearing is down here, in that kind of profound range, it will push you up to where the green circle is, essentially to normal hearing. And in some would argue that you have effectively superhuman hearing when you have a cochlear implant, because, when you're 70, 80, 90, or, 50, 60, you're hearing close to the level of a teenager. And then not only that, we found in children, their hearing appears to be more acute in many situations than other children, giving them something of an advantage. So what is the audiological criteria for cochlear implant? We don't just put in implants left, right, and center, but there's certain key hurdles before these implants will be funded in the UK. So they need to have an 80 decibel or more hearing loss at 2 or more frequencies in the range 0.5 to 4 kilohertz, and that's in both ears. They also need to have shown that there was inadequate benefit from hearing aids, and that is denoted in adults by them having a score, of less than 50% on the Arthur-Boudroyd test. And in children, we use age-appropriate testing. And they need to really have had this hearing aid trial for 3 months, and then an MDT decision. Now, this is important, where we will have speech and language therapists, audiologists, surgeons, teachers of the deaf will sit down and discuss whether a cochlear implant would be in the best interests of this child. So please, I would strongly recommend that this needs to be a team decision as to whether a child will benefit or an adult will benefit from a cochlear implant. Now, one thing I would add is these audiological criteria, which are set by NICE, the National Institute for Clinical Excellence in the UK, are amongst the most strictest criteria in the world. Unilateral losses will be implanted in places like Germany, and then losses around 70 even will be implanted in many other parts of the world, 70 decibels. So this is not a hard and fast global rule. This is within the UK context. Now, just some short videos. I was asked to put them in about cochlear implantation. On surgical technique, we can do a whole conference actually on this. And I had the great pleasure of visiting Iraq, the north of Iraq recently, to talk about auditory implantation, and I presented in numerous forums in Pakistan as well on cochlear implantation. I'm very happy to teach anywhere in the world because I feel this is technology which should be made available to children and adults all over the world. So very briefly, the approach is through a cortical mastoidectomy. You can see here, this is the sigmoid posteriorly, superior, this is the right ear, this is the tegmen superiorly, eye for the incus, lateral semicircular canal. You've got the facial nerve here, and you've got the chorda tympani nerve. Now, many otologists may never go to this extent in finding the facial and finding the chorda, but it is important to be able to do a cochlear implant. So now we have a facial, just showing in a real life patient, facial recess anatomy. We've got the tip of the short process of the incus. We've got the lateral semicircular canal. Here we have the facial nerve. And here this white structure is the chorda tympani nerve. And essentially you can see the facial recess is triangular shaped. And then here we have the round window niche. You've got the stapedius, and then you have the arch of the stapes, and this is the incus coming onto the stapes. So you can see through this facial recess, much can be seen of the middle ear. I'll just show a quick video of the facial recess dissection and round window. So essentially, the facial nerve is behind here. I've found the facial nerve. So now what I'm doing is I'm drilling anteriorly more so as to find the chorda tympani nerve, because that's my anterior landmark. The anterior extent of my dissection will be the chorda tympani nerve. You can start seeing a faint white line here now coming into view, and that there is the chorda. And as you do this dissection, the facial recess, as if by magic, starts opening up. You can see now we're beyond the facial nerve, which is here. We're drilling deep to that facial nerve. There's only so much space with this 2 millimeter diamond burr to fit in there. But what I'm doing now is I'm trying to make sure that I've got a good approach to the inferior facial recess, because you need that inferior facial recess dissection so as to give you the right angle to approach the round window. You can see I'm drilling now deep to the recorder here and the facial here. And the key thing is I'm keeping the shaft of the burr off the facial so as not to burn the facial, because you've got a 70,000 RPM drill there. Here you can see the stapedius, pyramidal eminence. This is the round window niche. Remember, there's a niche, there's a canopy of bone which overhangs that round window, and you have to remove that canopy of bone with good drill discipline, making sure your drill doesn't turn as you bring it out from the recess. And now you'll see the round window in good. So we've got probably 95% of that round window in view. The drilling of the canopy has occurred here so as to allow us access there. And then the round window will be incised, and then we will insert. So this is in a left ear. I'm going to show you a right ear insertion of the CI622 electrode. So you can see incision made in the round window. And I often will count these electrodes as they go down into the cochlear. You're going to try and make it as smooth of as an insertion as you can so as to prevent damage in the cochlear. And you have two white marks, and between the two white marks is where the insertion should go. So you can see there the final white mark, this is of the cochlear device, is at the round window, allowing us to say with certainty that we've got full insertion. Behind you can see this is a ground electrode. Not all electrodes are like that. So the key thing here is having a good approach to allow good visualization of the round window, and then to therefore make the insertion easy. You will see many videos by many operators, but I would argue that you should have an almost bloodless field with an excellent view of what's going on. So very briefly, how did we get here? How were cochlear implants developed? Well, the first sign that electrical stimulation can invoke sensations of hearing was with Volta. He decided for some unknown reason to insert a 50-volt battery cables into his ears, and he heard some sounds like boiling pudding. And then obviously that was a concept which then allowed the development then. So Journo and Iris, two French surgeons in cholesteatoma patients who were completely deaf, decided to put electrical stimulation onto the actual auditory nerve. The famous and legendary William House then progressed to implant two patients with single channel electrodes. So this was the actual first cochlear implant. Then other teams started implanting patients, and the first multi-channel device was with Medel and with Cochlear, and Clark in Australia put in a multi-channel device in the 70s, but it only really started becoming commercialized and more widespread really in the 90s onwards. So the commercialization was over the 80s, and around the late 90s onwards, that's when units started putting these in. In terms of, it was a multinational effort, so ranging from France to the US, Austria, and Australia. So these the efforts have been multinational, multi-billion-dollar investments to try and make this technology something viable for patients. And initially there were multiple different implants. In Middlesbrough, we helped with the development with the French company to develop the Neurolec device, and the 3M House device, which was a single channel. This effectively got left behind with the multi-channel devices of the other companies. And then Neurolec went out of business, and Oticon bought their device. But then, unfortunately, Oticon went out of business. So now we have the three main providers around the world. Cochlear provide about 50% of the devices around the world in terms of implants. And all three of these brands are available in Pakistan. Previously, there was a Medel monopoly. But we've helped introduce a lot of the other devices now. So you can see, as I was mentioning, around the 2000s onwards, it really started taking off. We started learning more and more about appropriate indications for cochlear implantation. And you can see there's been an exponential rise in cochlear implantation, such that in July 2022, there was a paper published by a Chinese team who basically put in the 1 millionth worldwide implant. So 1 million cochlear implants have now been inserted. In the UK, as of this year, there's been over 20,000 implants. The red dots indicate all the implant centers. So currently, we've now gone beyond simply putting in implants. We've now started looking at hearing preservation surgery. So where the high frequencies are down within criteria, but in the low frequencies, you still have good hearing. We can offer them either a hearing aid at the low frequencies with electrical stimulation at the higher frequencies. And for this, you have to put in the electrode in a very slow, gentle way, and you have to incorporate various other techniques so that when you put in this electrode into the cochlea, you do not destroy the hearing at the apical end. Implants now are becoming MRI compatible, even now, so much so with 3 Tesla implanting. Remote mapping is now becoming more and more widespread. And the indications, we're always pushing against those indications that have been set and trying to develop further indications, including for severe tinnitus. It's actually the most effective treatment available currently for tinnitus. So here is an example of the newer implants with MRI compatibility. You're still going to have some MRI artifacts, but here you can see the patient has a right-sided vestibular schwannoma that can be monitored while they have hearing on the other side. As you could probably work out, this is a patient who probably has NF2, which is why they've lost the hearing on one side, and therefore, they've got the cochlear implant unilaterally. As mentioned earlier, the population is aging. 1 in 5 20-year-olds today are going to live to the age of 100. And, I do a lot of medical legal work, and a common phrase which is agreed by experts is that 100% of 70-year-olds would benefit from a cochlear implant. So, you've got the population over 70 is just going to increase. By 2014, the population over the age of 85, all of whom will require aiding in some way, will have doubled. And many of these patients will have a severe to profound hearing loss. So this is, we have a massive demographic shift in the developed world towards an aging population, but this shift will continue with increasing healthcare outcomes in the developing countries, where currently the majority are the young people. So where are future directions? As I mentioned, tinnitus, single-sided deafness, this is already happening. Totally implantable devices are right on the verge of being introduced into the market. We're talking about drug-eluting electrodes to reduce inflammation in the cochlea and fibrosis. Robotic surgery is already happening in places such as in France, but not in a widespread manner. There are significant research trials now on optical laser infrared stimulation within the cochlea. And then I think, ideally, speaking as a surgeon, but as someone who's putting the patient first, ideally we would like to do away with cochlear implantation and have genetic transfer of neurotropic factors to rebuild and reconstruct the organ of Corti hair cells and the underlying architecture, so that patients can go back to natural hearing rather than requiring surgery and implantation of devices. And there's already been multiple vestibular implants, but these are still very much in the trial phase. So it's just on a side note. So here you can see with normal hearing, you've got approximately 3,500 inner hair cells. You've got approximately 30,000 spiral ganglion cells. With an electrical implant with 8 to 22 electrodes, you're only really going to be using a very broad brush kind of electrical stimulation strategy. When you have optical implants, you can have thousands of optical electrodes, which can then stimulate in a much finer resolution within the cochlea. This is what I was mentioning about reconstructing the architecture within the cochlear organ of Corti through gene transduction of neurotropic factors, which will then allow a reconstruction of the hearing mechanism. And I think ideally we would want to move to this. I think this is potentially on the horizon in the developed world. I'm hopeful in the next 15 to 20 years, you won't be needing cochlear implant surgeons like me anymore. Now, what about within the developing world? Well, you know, cochlear implantation has started, but, you know, in a very limited fashion. So within the UK, every child is offered bilateral cochlear implantation. But in the developing world, you know, they do not have this right to binaural hearing, and it's a very sad situation. Why? Because cochlear implantation is expensive. So it's £20,000 just for the device. If they're done in the private sector, surgeons will often charge $1,000 just to put this in. And then you've got the rehab costs as well. So, you know, you need the infrastructure you want a proper otologist who knows what they're doing. You know, and, you know, you're looking at 19 years of training in the UK costing approximately $5 million for an otologist who can then use a £100,000 microscope to place an implant safely. This is not easy, and this is why cochlear implantation is not commonplace in the developing world. As Dr. Haroon mentioned, I was invited to help set up the cochlear implant program, and within Pakistan, this child was this was the first surgery performed in Dow University Hospital in Karachi, and this was done in December of 2012. And within 9 to 10 years, the child on the right was our 100th cochlear implant recipient. All implants were delivered free of cost, and all the speech and rehab has been delivered free of cost to these families through the generous donation of donors from around the world. So just a little bit about the achievements of cochlear implantation in the developing world, specifically here in Pakistan. Life-changing CI provision has been provided since 2012 consistently, despite the challenges of working in developing countries. Someone mentioned about how they weren't allowed to have 2 hearing aids. You know, we've had similar issues where, you know, companies have tried to monopolize. You know, these are multi-billion-dollar companies, and they have a lot of power. So, you know, there's been a lot of challenges. We have challenges with follow-up. But, you know, these children are now going to normal schools with normal relationships. We've expanded from Karachi to Lahore and then onwards to Islamabad. And we would love to be able to provide this technology to children all across Pakistan and the developing world. Up to date now, we have now performed most recently up to 130 cochlear implants. And you know, each one of these was funded through charitable donations, and we've been very fortunate, and we're very grateful that we've had no major complications. We haven't lost a single implant. We also performed the world's first bilateral cochlear implant, the world's first hearing preservation cochlear implant, and then the world's first subtotal petrosectomy, blind sac closure, and cochlear implant, as access was not possible through the normal facial recess approach. And most recently, we did the world's second humanitarian blind sac closure with cochlear implantation. And now we have evolved to become the world's largest humanitarian cochlear implant program with 130 implants. The nearest humanitarian program, which is funded through charity, is I think 16 in Mali. where they're doing roughly 1 implant a year. We're doing over 10 implants per year now. And again, through the great work, teamwork of the charity IMRA and the generous help of donors around the world. And really, the sky is the limit. As one of our earlier speakers said, think big, achieve big. And, we're thinking bigger. Yeah, we're not resting on our laurels. So in conclusion and summary, cochlear implantation is the 20th century success story in otology and in audiology, I would argue. And if not just that, it is one of the great successes in healthcare provision generally, as evidenced by, 1 million implants being placed internationally. And as I said, we're very happy to help developing countries to develop their cochlear implant infrastructure. I think that's all I needed to say. Thank you very much.
Well, thank you very much, Naveed. This was an erudite presentation. I'm sure it was well received by all of us here. Very informative. And it's now time for panel discussion. I think we've gone over time. So I'll leave my mentor, Dr. Shabir Zaidi, to say a few words and see what he thinks we should do now.
I think we should discuss, because there have been so many issues that starting from Patricia to Shoaib and of course to Harun and Riaz, we can have, say, well, it's only 2 hours, not bad really. We can, but if Naveed has time and other people have time. Patricia, do you want, Mashni, you want to take up and start with anybody you want to ask? Any questions, discussions? Shahid is away, but the rest of the people are here.
Yeah, well,
Patricia, how about Guatemala? Would you like them to link up with somebody in Guatemala and Latin America?
I'm sorry, can you come up again with the question?
So these experts, would you like Harun, for example, running this charity IMRA, along with Naveed as surgeons, would you like to link up with these people and have their services extended to your part of the world?
Yes, I would love to. For instance, in Guatemala, the history of cochlear implants started when I got the training in Denver with Cochlear. And it took me months and months to find an ENT who wanted to get the training. I finally got one. And so in year 2000, in December, we started with 4 surgeries. And so after that, we started, but every single surgery had to be in the private sector. So it was very, very slow. Year and a half ago, I finally got some funding from the government. So this was the 2nd year that I was able to do, well, not me, the surgeon, 10 cochlear implants paid by the government and 8 bone conduction implants also. And so my program is, I would say well, there's 2, maybe 3 programs in the country, but mine is the one that's more structured, and has, all the by the book way to go forward with it. So it would be great for me to liaise with them, and also people from Central America. I know Costa Rica has a very good program because the government pays for all of the implants. But there are many countries that would love to have this kind of aid.
Thank you. Over to you, Mashir.
Well, let's open the discussion. Firstly, is there anybody who has a question to ask from the audience?
Dr. Mashir, I am Professor Mulazim Hassan Bukhari. Can I ask a question?
Of course, please.
So
go
thank
ahead.
you very much. Thank you very much, Professor Mashir, Professor Shabir, and Dr. Naveed, and Dr. Riaz, and Dr. Patricia. No doubt you gave the few references in the Pakistan and Karachi and Lahore. It was really nice to hear. I am not a ENT specialist. I am just a pathologist, but heading 3 of the institutions in the Pakistan. I would like to suggest that if you arrange such type of training program in Pakistan, at Lahore, especially Lahore or Islamabad and or Kashmir, Dr. Naveed, we would be happy that because it is not easy and not it is cheaper and it needs a lot of expertise and a lot of instruments and lot of setup. So can you visit anytime in our Pakistan, Lahore and Islamabad and Kashmir? So can we manage your uh, interaction with the government who can issue these budgets and can uh, 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 recognize these expertise in the institutions? One thing. Second thing is, yes. Second thing, as earlier Professor Shabi introduced that in Karachi, we are going to establish very soon a 500-bedded university hospital complex. And hopefully, Dr. Shabi, no doubt, you are the chancellor of this university, and also this is your specialty. I will request that, and especially at that platform, you will have such program, especially because it is not easy. And without any funded organization, we cannot do such thing in Pakistan. Thank you, Dr. Riyaz, and thank you, Dr. Naveed.
Do you want me, Naveed, answer this question?
Yeah, please, if you could. Thank you.
Right. So, I mean, you mentioned about training people in Lahore and Kashmir. So,
Yes.
I mean, so the two aspects. One is what we do, middle ear surgery, and the other is cochlear implants. We do in Lahore. We started at Mayo Hospital, and when the professor retired, the other professor took the microscope that he had brought to the hospital for 20 years. He took it home, so they have no microscope in such a large hospital, Mayo. So we shifted to Gurki Hospital. We have done 10 to 15 implants. It's one of the best hospitals I'm sure if you're from Lahore, you know Gurki Hospital. If you're not visited, it is as good or better than a lot of hospitals even in UK. So we are prepared to train. It depends, who wants to train and where. We go there twice a year, and we are going next month. Naveed is going. We're going to do implants in Islamabad. It's already been planned. It's 7 implants planned. We're doing middle ear surgery in 2 centers next month. About 50-60 mastoid will be done, Karachi and Mirpur Khas. So we've got very well structured. About 20 trainees, FCPS trainees now come to our program. We earmark them in theater, and then they watch on the screen, and then there's a rota. In the last couple of years, they have been training, and some of these trainees have now been brought to UK by IMRA charity to have further training. So, and one of them is being trained at this moment of time in a proper program with Dr. Naveed. If I want to tell you, is the first otologist who will be going back to Pakistan with a proper cochlear implant training at a UK standard. So we are doing what we are. We are prepared to help Kashmir. If you can elaborate a few bit more details, or you want to contact me or Naveed later on through Professor Zaidi or directly, we are prepared. So we want to spread and train. Our ultimate objective is to train the people in Pakistan to do it, so that Naveed doesn't have to keep flying back and forth,
Thank you so much, Dr. Harun and Dr. Naveed. We are expecting your presence in Kashmir very soon, inshallah, in future.
Inshallah. Yeah.
I should add that.
Dr. Harun.
I should add that Professor Muzammil Hussain is the
Mulazim
principal.
Hussain, sir, Mulazim Hussain. Dr.
Mulazim
Mushir.
Hussain. Yes. I beg your pardon. Dr. Mulazim Hussain is the principal of.
I am the servant of Hussain. I am the servant of Hussain.
Indeed, we all are. So he's the principal of the college of the medical college in Azad Kashmir in Muzaffarabad. So he's well connected there, as well as in Islamabad and Islamabad.
Thank you, sir.
So
Kaisa Sajjad on the screen.
Yes, Harun Bhai, thank you very much. And good morning, Assalamu alaikum, everybody.
You introduce your credentials first. Your secretary
Okay.
of PMA.
Yeah, I was the Secretary General of Pakistan Medical Association, and I am
Sir, your
lucky
name, sir,
that
your name.
my name is Dr. Kaisar Sajjad.
Dr. Kaisar Sajjad
Yes, sir,
is very
Sajjad.
well known in Pakistan for
Yes,
Yeah.
Atollos,
So,
ENT specialist.
yeah, I'm very much lucky that I am also the part of the IMRA with the support of Harun Bhai, and I am very lucky to work with IMRA, and I offer my services as Dr. Mulazim requested for training in the Kashmir, Lahore. So I'm here to liaison in between. I'm here to everything, whatever Harun Bhai, Dr. Harun say to me, any duty, impose any duty, I am here to say. I have a question to Naveed also, that Dr. Naveed, can you just, I would like to know about the cochlear implant on the adult person. It's very, I mean, people are talking about, and some people are coming to me, even I'm practicing in Karachi as an ENT surgeon. So people are coming, and that Dr. Saab, I would like to have this cochlear implant or this and that. My child is age 40 or 45. So what is the advantage or what is the success rate of this cochlear implant in adult?
Sure. So
Before Dr. Naveed answer, let me tell you one thing. Dr. Naveed is the person in the UK who has implanted a person of 80 years old, more than 80 years plus.
103.
Okay.
World's
It's
largest,
103.
oldest.
Yeah. I heard
World's
the
oldest.
news even. That's why the people are asking about having this news about the Dr. Naveed about the cochlear implant on 103 years old person. Yes, go ahead, Naveed. Thank you.
Sure. So in terms of adults, one thing I will say is, in actual fact, the majority of cochlear implantation now around the world, in the UK, or I should say in the developed world, is in adults. And it's at two extremes of age. So you have the very youngest patients. So that's limited to 1 in 1,000. But then you've got the older population. We're talking the people over 70, 80, around 90s. This population is growing and growing and growing. So, you know, since at least, I think, about around about 7 to 10 years now, the majority of implantation now is in adults in the developed world. And it's actually very successful. These patients already have developed speech. They already have language. So all you're now having to do is give them their hearing back. The reason why we've prioritized children is because if you lose that window of opportunity up to the age of 3 or so, they will not develop speech, at least not normal recognizable speech. So that's why we've had to focus on the children. But in actual fact, the need for adult implantation is greater in terms of numbers. So absolutely. And in adults, your outcomes will be easier because they already have speech. You just need a good audiologist who can then tune the device for them, and they already have the speech and they can just work with that device. So I would say it's not only viable, it's actually the majority of implantation. And the other thing is, as very kindly people pointed out with the world record breaking case of 103, what essentially we were trying to show there was that there is no upper age limit to cochlear implantation. I know in the developing world, people say, well, when you're 70, 80, just sit on your bed and get ready for the next life. Yes. But in actual fact, what we're trying to say here is that even if you're 90, even if you're 100, you know, you can still have a quality of life from hearing. And the other key thing I wanted to say was, you know, dementia is an avalanche that is waiting to hit our older populations. And hearing loss has been shown to be linked to dementia. And you have to treat hearing loss in order to prevent dementia. So it's very, very important that we start treating this older population. Unfortunately, because we have a purely charitable program, we have a limited supply of implants. And on ethical grounds, we therefore focused on the children for whom it would be a lifelong impact. And as Professor Shabi said earlier, the QALYs in a child are far greater than the QALYs in a 90-year-old, because the child will benefit from the cochlear implant for the rest of their life, with development of speech, etc. And in an older patient, you know, they may get a few years out of it. But I will say, someone asked me the question, why did you do this 103-year-old? He was going to die anyway. Well, I can tell you all, 2 years later, he's still alive. So he's doing well, you know. So there is no upper age. Thank you.
Okay, thank you very much, David. I think
Can I say something, Professor Shabi Zadi?
Yes,
excuse
just
me.
identify yourself.
I'm just give me a minute, Dr. Mubashir. Thank you very much, Dr. Naveed. I hope that see you in Karachi, maybe in Nawab Shah. Is this time I'm planning to be there in Nawab Shah, inshallah ta'ala. And my request, Mirpur Khas, sorry, Nawab Shah, not Mirpur Khas. And my salam and regard to my mentor, Dr. Shabi Zadi is here. I heard him because I joined late. Assalamu alaikum, Dr. Shabi Zadi, Professor Shabi Zadi. Thank you very much, and I'm glad to listen your voice. Thank you, Naveed. Thank you, everybody.
Thank you, Qasser. Good to see you and good to hear. You're also attending our course in certification of medical education, which is wonderful. Thank you. You're welcome.
Yes.
I am Professor Umar Farooq. With your permission, sir, can I say a few words?
Yes, go ahead, please.
My name is Professor Umar Farooq. I am a practicing ENT surgeon here. And if you allow me an additional few seconds to introduce myself, when I born in ENT department, I spent my infancy and toddler's age with Professor I.H. Jaffrey, was one of the great surgeons here. And when I start walking, I hold the finger of Professor Shabi Zadi. And in this way, till now, I am in contact under guidance of him. I have achieved a lot. I've started the functional endoscopic sinus surgery and the cochlear implant with the help of Harun Sahab and Imra. I was trained in 2012 in UK with the help of Imra, and I'm thankful to them. At that time, I was the Pro-Vice Chancellor of Dow University of Health Sciences, and when Dr. Haroon came to me, and he said he has the vision and will to do that, and up till now is not finding the platform to start with, I was the one who started with them in Dow University of Health Sciences. And I think Naveed must be remembering the time he spent here in our hospitality. I just wanted to add a few words said in response to Qasser Sajjad by Naveed. Here in Pakistan, being the third world country, the people are not aware of the real fact that what cochlear implant serves. The question of in one perspective only, and that was the post-lingual deafness in adult children, patients. And there a lot of patients now comes after hearing that the hearing implant helps the deaf people, those who are having a pre-lingual deafness, that they are deaf by birth, deaf and mute by birth. So in that cases, the cochlear implant does not help them in developing their speech in those who have already not developed the speech. So in those cases, those who have passed the age of 10, 11, 12,
though cochlear implant has got no place. And then only the post-lingual deafness. I also had operated a 84-year male in Pakistan who was a post-lingual deaf and was having the problem. And now, after I think 5-6 years, he is alive and mashallah doing well.
So, do you have a question?
Yes, I just added a point in Navee's comment that those patients, older patients, those who already have developed the speech and were talking and has lost this has lost the hearing now, they can be helpful, but those who are not cannot be helped.
Okay, thank you. Any other question from anyone?
Hello.
Yes, please go ahead.
Good evening. I'm Professor Dr. Suhail Malik Qureshi, and I am working as a head of the Department of ENT and Head and Neck Surgery at TMK, Hyderabad, Pakistan. And
Welcome.
I will just a few words about Professor Shabir Zanzadi. He's not only my mentor, but like a father. What I am now is just because of him. So it's unfortunate that he is moved out of Pakistan. He is there in UK, but sir, it's great. He is doing a great service to humanity history. So thank you very much, sir. And it was very informative meeting. Thanks.
You're very welcome. Professor Shabir Zadi is here. I'm sure he's listening.
Thank you, Suhail, and thank you, Farooq. You're very kind. Of course, if I'm allowed to say, my oldest, not old, the youngest oldest is Mushir. I think Mushir, you were there in 1972 or 73, maybe around that
Well,
time.
I graduated in 77, so I started medical school in 72, yes.
Yes.
Now
I
I'm
also joined the medical school, that is Dow, as a teacher in 1972. So we have long association. Mushir is my student, and he's the teacher of my son, who's now double professor in Mount Sinai. So we have relationship. Education is an amazing bridge, it bridges the ages, the gap, the races. It's transcendental in character. So it's such an opportunity to see everybody. Thank you so much, Suhail and Farooq. Very grateful. Over to you, Mushir.
I am feeling very young. Among the senior people, I am the youngest of your students here.
Yes, well, any other questions?
I have one, if I may.
Please go ahead.
I have one for Naweed. How are you managing the follow-up of the cochlear implant recipients? That's one of the issues we're facing right now, because the government is paying only for a year of spare parts, speech therapy, mapping sessions. But most of these people don't have the resources to pay for their own cochlear implants. So what we're facing right now is that if the patient needs whatever spare part or repair, so how do you work this out?
Sure. So what I'll do is I'll answer this in two parts. The first part I'll answer. The second part, because it's funded by the charity, I'll ask Dr. Haroon to step in for. So the first key issue with all cochlear implant programs is to remember it's not about the implant, it's not about the surgeon. It's about the team, and it's about the long-term follow-up of these patients. I would argue that 1 year is not enough for a child. You need to have 2, minimum 3 years of rehabilitation. So you need a functioning implant with all the batteries, all the wires that are going to get lost, all the speech processors that are going to get eaten, all of these things. You need to be prepared to keep that child in your program for 2 to 3 years. So so in terms of follow-up, we always test the families first. So what we say by test, I mean, we tell the families, you will not get an implant until you have demonstrated to us your willingness to stay within a rehab program. So these children are given they're given up to even 6 months of speech therapy with a hearing aid, and their follow-up is analyzed. Did they miss appointments? Did they make excuses? The family make excuses. Did they stick with you before the implant? Because if they stick with you prior to the implant, they are likely to stick with you after the
Correct.
implant. So it's
Correct.
two-sided. So one is the family and the child has to come to you. And the second part of it is in terms of you need to be in there for the long haul. 3 years of rehab, 2 years of rehab minimum. And for that, we always fund that in. So when we say, right, we're going to give someone an implant, we make sure there's at least 3 years worth of speech rehab with that. In actual fact, for audiology, all our patients are provided lifelong follow-up, but that's through the charity. So on that point, I'll hand over to Dr. Haroon, who provides the money and the resources for this
Right.
follow-up.
Okay, there's just one bit. The rehab team we have in Pakistan, especially in Karachi, have over 30 years of experience in dealing with cochlear implant. That's the first thing. Secondly, they have also been trained in UK. They've spent time to see how things are done here. And then from time to time, we advise the companies that we buy the implant from, especially AB, who arrange courses in Dubai. And we send them, say, every couple of years, so update them. And then there's an online, also training for them. So they are very well organized to deal. Now, coming to the financial part, you see, this charity, we do fundraising mainly in UK, fundraising events, and we collect donations. We do fundraising in Ramadan when people are charitable. We do have some fundraising in America, registered in America as well, and we get some support in Pakistan, which is not much, but our main funding in the UK. So we just get enough money to support these children that we implant, and we allow them, you see, if they can't afford rehabilitation or the processor is lost or broken and is out of warranty, we supply them. So we want to make sure that no child, because of money or whatever reasons, is devoid of any equipment that is needed following an implant surgery, because otherwise our work will be wasted. So it's mainly through fundraising, donation, support, all kinds of support. Our costs are minimum, because every time Naveed flies, he buys his own ticket. We don't pay him. We don't pay for any accommodation, hotel, anything. Our rehab team, that is not they're not employees, but they charge 50% less than the market rate if somebody can pay. If somebody can't pay, the charity pays for them. So this is how we support the program.
Okay, thank you very much.
Right. Any more questions? So before we end, can I ask you a question? I have a question for Naveed. What is your view about giving corticosteroids with the implant to preserve low-frequency hearing loss? Is that reasonable now?
Certainly. So what we do is we give intratympanic steroids just before the surgery actually starts. We give high dose dexamethasone at induction, and then another high dose of steroids just before the implant goes in. So there's a whole process involved in hearing preservation surgery. Steroids have been shown to benefit in hearing preservation. Beyond that, there's other factors like how slowly you insert the electrode, what kind of incision you make on the round window. So even to do with what kind of fluid you use in your irrigation, all of these factors add up and incrementally improve the chances of hearing preservation. There's whole conferences on it, but that's a very rough summary.
Right, thank you. The other question was, you'd mentioned that in a case you had to take another route because there was some anatomical difficulty. Was that with the facial nerve anomaly?
Certainly. So facial nerve was very far anterior in one case. It was almost up to the recess was absolutely tiny. So there wasn't much space between the annulus and the facial nerve. And in the second case, which we did for Imran recently, the sigmoid sinus was up to the ear canal, but then on top of that, even after decompressing the sigmoid sinus and getting to the recess, the cochlea was so posteriorly rotated that you could not see the round window. You only saw the anterior part of the promontory, and that's not enough. So in that case, made a decision to take the ear canal down, subtotal petrosectomy, blind sac, and then it was very easy to find the round window.
Well, it was very sensible. I think, no, I'm not in a cochlear implant centre in Dundee. We don't do this. As you know, it's in Ayrshire, the Scottish Cochlear Implant Centre. But in my training, I did come across a cochlear implant that had a facial nerve anomaly, and we were doing it. And Chris Rain was with me in Bradford, and we reported it in the annals. So it was published, and it was, as you say, in front, and you face the facial nerve. But Chris was able to push the nerve back and did the implant, and the results were all right. So he was quite pleased about that. So is there anything
Sorry,
else?
I have some comment, please, Dr.
Go ahead, Dr. Shah.
Dr. Habib. Yes.
Yes, Habib Shah.
Okay. Thank you very much for everybody who participate in this meeting. I just have few words to say. Is after these discussions and a lot of informations and a lot of people, brilliant people who participate in the field of hearing loss and cochlear implant and rehabilitation, I think we have to think seriously about to collect these people together, connect with each other. I think it's better to say, for example, an international, small international group to further collaborate, to further communicate with each other, Iraq, Pakistan, UK, yes, Patricia from Guatemala, and all people who are willing to participate, because working together will help all of us. Actually, in Iraq, we have a running cochlear implants, but we need your input. You need the input of Dr. Naweed. We need the way of work of Imran, because a lot of our people are suffering. And I think seriously to initiate a similar, for example, association or effort to help people in a charity manner. So a lot of ideas, a lot of work. But I think we have to collaborate more and more seriously to develop, to improve our situation, and mostly to evaluate our steps. We are running cochlear implant in Iraq since maybe more than 15 years. So we need your input to evaluate our work and to go further forward. So it is a humble suggestion to maintain this collaboration even after this session. And thank you very much.
Well, thank you for the
Thank you.
notes. I'll invite Professor Shabir Zaidi to make the closing remarks.
Thank you, Mushir, and thank you, everybody. But before that, can I just answer to what Habib has suggested? So what we're doing is that Medics International is collaborating with Warisul Anbiya Hospital, the university hospital that's coming up. And also we have engagement with you. Next time, when you have a plan, maybe Naveed can come with us and Harun can come with us to Kufa and then visit other places. There is, and not just for observation, but also assessment of your program. Because without assessment, you cannot have any progress. And reflective thinking is a part of, as you know very well, Habib, it's a part of development of a program. So for assessment and for advice, we should plan out whenever it's convenient for Naveed and Harun to come with us with a group of Medics International. Dr. Bukhari goes there regularly, so we can work out at their convenience. That's what's first thing. Second thing, of this wonderful discussion, what I feel is that we should engage WHO for an international program. I mean, they used to have this program called Blindness and Deafness, in which I was involved many, many years ago. I am in touch with Gohar Wajid. Gohar Wajid is professor of medical education. He is also the technical advisor to WHO on all these programs in EMRO. Very close friend. I actually spoke to him earlier on. He is visiting some friends in Cairo, otherwise he'd have joined. So we should develop a plan, and maybe we can engage Latin America. India somehow could not come today because Farzana Mehdi and the people are busy, but we'll engage them also. Think of a plan. Mushir, maybe you can come up with this plan that we can develop a cohesive program for WHO somehow to get involved. Now, WHO has funds. I know very well. They have funds for disabilities. Deafness is far too below blindness. Blindness always gets a top priority. And that has been the battle for a long, long time. If we can convince them through you, maybe you can write a proposal. That's one thing. Second thing, we know the president of Pakistan Science Foundation, Professor Shahid Beg, who's a very close friend of Sadiq International Virtual University. And he offered us that if you come up with a proposal, a research project, then they have funds available in Pakistan through multinational companies and agencies. So Naveed, if you can come up with a project for research development, like, something to do with Pakistani society, which can be replicated in other countries also, like Iraq, for example, or even Guatemala. They have something like $20 million in their pot for research grants. So that is the second thing. The third thing I'd like to mention is that I've spoken to Harun before, that as you go for surgical operations in different cities like Nawab Shah, Lahore, Islamabad, maybe we can link up with you, the Sadiq International Virtual University, and get your surgical the procedures transmitted right across the world through our LMS. We have very advanced learning management system. Like I said earlier on, it's supported by AI, and we have a perfect system we can transmit across the world. So if you have surgical techniques that you want to teach to other people, because yours is very advanced, then we'll be happy to share this. So next time, whenever you go to Karachi, Lahore, Islamabad, let us know. We'll link up with your team. And I spoke to Harun about that. That's the first. And finally, I'd just like to thank everybody. It's been a wonderful discussion. Mushir, thank you for handling it. Harun and Naveed and Riaz and Shahid had to go away. And Patricia, thank you so much. But connect us to Latin America and South America for other activities that we carry on. Habib, thank you so much for joining in despite your engagement with the academics. Thank you so much. And once again, thank you all. And we'll meet again in due course of time. Over. Anybody else wants to comment before we just close off?
And just my final comment is to you. I mean, you are an inspiration, and I just want to correct, Mushir is not the senior. I am the senior because I was your trainee before Mushir. So I should get the medal.
Actually, to be honest, I was the house officer and Dr. Harun was the registrar.
Yes.
And
I remember the first ever
down the ladder.
The first ever laryngectomy I did was with Harun.
Anyway, so we'd like to thank you, and we hope we will continue, and all the kind words and good words said by everybody. And it is really a good beginning. And IMRA will do everything to help anybody anywhere. And I and Mujid are prepared to go to Kufa next year. We'll try and plan it. And then the thing you mentioned at the end, next month we are doing middle ear surgeries all online. I will try and connect with your university so people can watch these surgeries. So we can do that for you.
And if you are in Karachi in December, come to attend our ceremony. The hospital that we're starting, we laid the foundation last year. We have raised the fund something like $1.5 million in America. It is being funded by American doctors.
So which date is which date?
This is we're not fixed the day. There's fundraiser on 17th of December, but the main function will be around 23rd of December when we'll start the digging properly. It's going to be a 7 or 8 stories building, and that'll be a university hospital. in which doctors from America and Canada directly, or England, for example,
Okay.
they're directly involved in its building. So they'll go for training and teaching, and God willing, it'll be a good project.
Thank you. Inshallah.
Part
Yes,
of the physical structure of Sadiq International Virtual University.
thank you.
So you're all
you.
welcome.
So, and we'd like to thank Mushir for conducting this whole program very well and keep everybody online. Thank you very much, all of you, and inshallah we'll be speaking soon, you know.
I can
Thank
only
you.
say, in terms of, I'm just following our leader, and there is a Persian poet, Hafiz, which all of you will know. He said something about this, following your leader, that if you follow the leader, you don't have to worry because he will take you to the right path. And it goes like this. به می سجاده رنگین کن گرت پیر مغان گوید که سالک بیخبر نبود از رسم و راه منزل ها. So the leader knows the way to the path. So I follow him. Whatever he says, I do.
Thank you, Mushir. Have you done your master's in the Persian thing that you were doing?
Yes, I was awarded a degree. I was awarded a degree in Persian history and language last year from St. Andrews.
Wonderful.
Yes, I did that. And I've gone back to teaching medical students now and gone back to work at Nine Wells. So,
and you're again the editor of Logan Turner, The Bible, which made me pass my FRCS. Otherwise,
yes, I did the last edition and the new edition is coming out. We've completed all the chapters, I think, but 2 chapters left. So I expect it will be out in the summer of next year, the 12th edition of this 100-year-old book.
Great achievement. Thank you all. Until we meet again. Goodbye. And Patricia, keep in touch, please.
Okay, I will. Bye-bye. Thank you for
Bye-bye.
inviting me.
Bye-bye.
Bye-bye.